Yeah, I'll hand over to Morten. Thank you for being here.
Thank you, Shelley. And hello, everybody. Good afternoon if you are in Central Europe. Good night, good evening, and good morning to the rest of the world. I'm very excited to be here with you all today. If you're using your time with us covering such a relatively broad spectrum of knowledge in our field of sound and acoustics, you are truly my colleagues, and I'm thankful that we can all share this time. You know, there's a lot of turmoil in the world, been going on for a long time now, so having some time to really delve deep into what really interests us and what motivates us, I think is really great. We have two amazing researchers with us today, so I won't waste a lot of time for you just listening to me when we could be listening to them. So they are, of course, Kasper of the ISOBEL project, which we will hear from later, and then Mette of the Danish Cancer Society, who will be talking about environmental noise. And environmental noise is considered the worst environmental health risk factor by the World Health Organization, right after, of course, air pollution. And this has been known for quite a while. I think perhaps it was around 2012, even though I'm not quite sure right now when environmental noise got this classification. But even though we see the realm of knowledge in this field sort of expand and expand, unfortunately, in the global scene, we don't see as much action on it. But luckily, we have senior researcher Mette with us from the Danish Cancer Society. She is one of the most knowledgeable scientists in the world, working with or exploring the epidemiological effects of noise. And she and her colleagues have recently conducted a broad study on the entire Danish population and uncovered some highly interesting facts. And before that as well, I should mention Mette have worked with this for a while. So I'm very happy and I'm proud to be presenting Mette Sørensen. So Mette, please go ahead and take it away.
Thank you, Morten, for this nice presentation. So thank you for inviting me. I've looked forward to share some of our research results today, and I will, as Morten said, be focusing on our study, nationwide study, including all of Denmark. So Morten also already mentioned this a bit. I think it's important that we just look a bit on how widespread a problem transportation noise actually is. According to the European Union, they say that at least 20% of the European Union population are exposed above 55. And I think I've underscored this at least because they acknowledge themselves that this is very likely underestimated. So in Denmark, the Danish EPA have estimated that 28% in Denmark are exposed to road traffic noise exceeding these 58 decibels. And as Morten says, WHO calls it the second largest environmental pollution in Europe, only exceeded by air pollution. This also means that when we have exposure that are so widespread, even small increases in risks of different diseases can lead to actually many disease events because so many are exposed to actually high levels of this exposure. So first of all, why is noise at all harmful? A lot of people still have difficulties understanding why noise can be harmful because it's not something we inhale, like for example, for air pollution. But we think that there are two major mechanisms playing in here. And the first one is that if we are exposed to noise during daytime, it can stress us. What we know is that it can activate what we call a stress stress response, where the body mobilizes resources to either fight or flight from a situation that it considers as dangerous. And that was, of course, really good. It ensured our survival 100,000 years ago. But in our modern world, these acute noises, if they lead to this stress response, it can be a problem if we have chronic exposure to such noises. Also, and what we think might be even more important, is that if we are exposed to traffic noise during night, it can disturb our sleep. And we know that it can lead to both these, what we call the conscious sleep disturbances, which I think that basically all of us know, that if we are exposed to noise when we try to sleep, we have difficulties falling asleep, we maybe wake up earlier. But what we can see is that if we expose people in the lab during night, we can see that also they tend to spend less time in what we call the deep sleep, the slow wave sleep. They also have a reduced amount of REM sleep, and this is important because we know that this, especially this slow wave sleep, is really important because the body restores during this sleep, and if we have less of it, it's can of course increase risk of different diseases. So which diseases are we talking about? The research on noise started with cardiovascular disease because we know that both stress and sleep may increase the risk for hypertension and other risk factors like inflammation, endothelial dysfunction, which are main risk factors for developing cardiovascular disease. We've also been looking on obesity and diabetes because we know that people that don't sleep well, we know that they have a decreased in insulin levels. We also know that if you sleep poorly, you will have an increased level of blood glucose in the morning. And there's also been some studies showing that it may interfere with the hormones controlling whether we are hungry or not. So these are all risk factors, potential risk factors for obesity and diabetes. And also risk factors for dementia. Some of these risk factors are the same, like inflammation, endothelial dysfunction, are also associated with an increased risk of dementia, but also these disturbances of the sleep stages. So slow wave sleep, REM sleep is important in relation to dementia, especially Alzheimer's disease. So when we started this national study, what did we know about noise and health? It was just around here where WHO in 2018 came with this report that you can see here, where they had an expert panel of a number of researchers within the noise field to look through all the literature that were available at that point in time. And what they ended up concluding in these guidelines was that there were high quality evidence for concluding that there was an association between road traffic noise and ischemic heart disease. And if we try to add some numbers on this, they found that a 10 dB increase resulted in an 8% higher risk of ischemic heart disease, or for the European Union, this results in around 50,000 extra cases of ischemic heart disease in 1 year. For all other diseases that they evaluated, and they evaluated basically all diseases that had been suspected of being associated with noise, they concluded that there was insufficient evidence due to the lack of high quality studies. So for many of the outcomes, for example, blood pressure, there was a number of studies, but they didn't have this high quality studies. So the aim with our study was, of course, to help this evidence a bit and conduct high quality studies on transportation noise and major diseases. And here I will focus on stroke, diabetes, and dementia on a national scale using the unique Danish administrative registries and the health registries. So, as I said, the study population is entire Denmark. And just, I think it's important to say how amazing it is that we can conduct these studies. I think we are basically the only country in the world that can do this so far back. Our Nordic neighbors also have the possibility, but their registers don't date back as long as ours. So it is because we have our unique health registers, we have our administrative registers, and this is what makes it possible for us to actually conduct such studies. And one major reason that this can be conducted is this card. I think everybody knows this card is our social security card, and on this card is our CPR number, this 10-digit number that enable us to link all our registers. So, as I said, we have the entire Danish population. In our study, we focused only on people that were more than 35 years of age, because these are diseases that you develop at an elderly age that we are investigating. So we had in our study population 3.6 million. And what we did for these 3.6 millions was that we went to the CPR registry, and in the CPR registry, you can go for every person living in Denmark and find their complete address history. Actually, you can find it back to 71, but we focused on noise from addresses from 95 to 2017. So for all these 3.6 million, we have address history from the period from 95 to 2017. And what we did then with these addresses was that we sent it to a noise consultant. We, of course, geocoded it and then sent them to Rambøll. And Rambøll then estimated traffic noise at all these addresses, both now and back in time. We also sent all these addresses to Aarhus University, because Aarhus University are good at estimating air pollution, and we wanted in all our models to be able to adjust for air pollution or take air pollution into account, because we know that air pollution is suspected of causing the same diseases as noise. So we want to be able to adjust for this exposure also in all our analysis. Then we have a number of these health registries, and when it comes to stroke, we use the hospital registry, which records all contacts to the hospitals. We have a mortality registry, and based on that, we were able to identify 185,000 that developed stroke during this period that we looked on, from 2000 to 2017. We went to also again the hospital registry and the prescription registry, where all redeemed prescription are registered in Denmark. And using this registry, these two registries, we found 234,000 diabetes cases. And again, these register again the hospital registry, and we also have a psychiatric registry, and again the prescription registry. And combining these three registries, we were able to find 103,000 people that develop dementia. We also use a number of registers at Statistic Denmark. At Statistic Denmark, they have registers that have information on different variables saying something about a person's socioeconomic status. So for everyone living in Denmark, we have yearly information on their income. We know their level of education. We know whether they live together with another person or not. We know their education, whether they are born in Denmark or not. So from these registers, we have a number of information on socioeconomic status, which is of course important also to adjust for in our models. So as I said, we sent out our geocode for all the addresses to Rambøll, which were responsible for assessing exposure. And what we assessed, or what we used, was the Nordic prediction method from '96, embedded in SoundPlant, and input variables were, as I said, the geocode. And not only the geocode, we also estimated the floor. So we included the height also in the geocode. We included screening from buildings, of course. We also had information on state noise barriers and included also information on terrain. And we included first and second order reflections also. And then we estimated exposure to road traffic noise. And for all road lines in Denmark, we had information on the traffic composition, yearly average daily traffic. We had information on the traffic speed and on the road type. And this is how that looked in sound plane, where you can see in red the road lines where we had all of this information. And similarly, we also estimated exposure to railway noise, and we received these information from Banedanmark, the annual average daily train lengths, train types, travel speed. And what we did was that for all of Denmark, we estimated noise at all addresses that were within a kilometer from a railway track. And this is how it looks when you actually estimate road traffic noise for entire Denmark. So you can see here I plotted in all the addresses for road traffic noise, and you can see how that distributes across Denmark. And in this study, most previous, or basically all previous studies on noise and health looked only on road traffic noise at the most exposed facade. But what we wanted to do in this study was also to try to estimate noise at the least exposed facade. And we wanted to do that because we know that people only often select to have sleep in a room that is facing away from a busy street. So we see this least exposed facade kind of as a proxy for the exposure you have during sleep. And actually, we don't see a strong correlation between most and least exposed facade. So it seems that they are capturing different things. And here in this picture to the right, you can see how that looks for Copenhagen. Here we have road traffic noise at the most exposed facade in Copenhagen and at the least exposed facade. And what you can see is that when we look at the least exposed facade, some of these central areas in Copenhagen become almost silent. And that is, of course, because we have these inner courtyards for many people living in Copenhagen, that is there where you don't actually hear the traffic noise that clearly. So to the results for the dementia study, I just wanted to give to sum up what we have of information for our study population in dementia. Here we only focused on people that were 60 years or older, because dementia is a disease that only develops in people above a certain age. So we had 1.9 million persons, and of these, a little more than 100 developed dementia. We also tried to look at different subtypes of dementia. And here we found 31,000 with Alzheimer's disease, a little less than 900,000 with vascular dementia, which is a dementia caused by a stroke or similar in the brain. And a little more than 2,000 with Parkinson's disease. And so for all of these 1.9 million persons, just to recap, we have information on road traffic noise at the most and least exposed facade, railway noise at the most and least exposed facade, air pollution at the addresses, and also this information on socioeconomic status. And I just want to take you very briefly through the statistical analysis, not kind of the name of the statistical analysis, but more what do we actually ask this statistical analysis to do. So what we use is something called Cox proportional hazard models, but basically what we ask it to do is that here we have our population, the entire Danish population. And as you can see, here is a person that went into the study in 2004, and then he lives until 2015, where he develops dementia. And then we ask the statistical program to calculate what is the 10-year mean, taking all addresses the 10 years before the dementia into account. For all other persons living in Denmark, and I should maybe just say that this person was 75 years of age when he got his dementia. For all other persons at the age of 75 without dementia in entire Denmark, we do the same. So at the age 75, we ask the program to calculate 10-year mean noise, 10-year back, and then we of course see whether there's any difference in the exposure among persons that develop dementia compared to persons that do not develop dementia. And we take into account socioeconomic status, sex, and air pollution. So here are the results. First, for all-cause dementia, that means that in this analysis, we have these 100,000 cases. And just to take you through, this is road traffic noise. This is railway noise. Up here, you can see the risk. The higher up here, the higher the risk. And in blue, you can see results from the least exposed facade. And in pink, it's the results for the most exposed facade. And what we can see is if we start with the most exposed facade, we see an increase in risk rather nicely until around here, where we actually do see a leveling off. For the least exposed facade, we see a steeper increase, suggesting that we see a stronger association with the least exposed facade. But again, we see this leveling off at high exposures. For railway noise, we see the same for the most exposed facade, an increase and then a leveling off, whereas for the least exposed facade, it's not that clear. We don't see the same leveling off, but we see an increase in risk at high exposures. And if we then look at the different subtypes of dementia, so in blue, you can see the Alzheimer dementia. In pink, you can see vascular dementia. And in orange, you can see Parkinson's. And in this figure, we show results for the road traffic noise at the most exposed facade. And here we show results for the least exposed facade. And just to guide you, what we should start by noticing is that these increases are much steeper. They go up higher. So least exposed facade seems to be more strongly associated with dementia than most exposed facade. We see also that for Alzheimer, the risk goes up a bit higher than it does for example, vascular dementia. But again, we see this leveling off at high exposure levels. So we were a bit puzzled about this leveling off at high exposure levels because this was basically not what we assumed. So we tried to look into explanations as to why we see this leveling off. And we did that by doing analysis. This is again all-cause dementia, so all subtypes together. And what you can see in this figure, it's road traffic noise at the least exposed facade. And here you can see the exposure, but we tried to separate into people living in low density area, that's the pink line, in medium density, so that's kind of suburban areas, and then in high density, which is kind of central Copenhagen, central Aarhus. So this is high populated areas. And what we could see was that when we looked at the areas where we had low population density, we saw a nice increase throughout their exposure range, whereas it is when we come into more urban areas that we see this leveling off. We also tried to look at it in another way where we had looked at different types of houses. So if we looked on single family houses, that's the pink line, compared to semi-detached and multi-story buildings, we again saw a stronger, we see some leveling off, but not as evident as it is for multi-storage buildings. So it seems like it's something that are happening in the cities that are causing this leveling off. So our potential explanation is, and I think maybe the first one I list here is the most important, that in these cities and also suburban areas, We have a number of other sources of noise. We have, if you live in multi-story buildings, for example, you have neighbors, and we know that that generates a lot of noise. We have noise from restaurants. We have noise from people talking in the street. So we have a lot of other noise sources that are masking the noise from the traffic noise, which may cause this leveling off in effect. Also in these metropolitan areas, we could also think that people were more likely to invest in better sound insulation, and also in these complex city areas, it might also be that we have a higher misclassification of our noise because it is a complex building dimensions. So that is our possible explanations. So to do general conclusions here for dementia, we found an association with all-cause dementia and also these subtypes, especially Alzheimer's. They follow this linear exposure-response relationship, but we saw this leveling off, as I just said. I didn't show the results, but I can say that all the associations were robust to adjustment for air pollution. And we saw these higher levels for the least exposed facade, which indicates that sleep may be, or disturbance of sleep may be especially important here in relation to dementia. So I will also present our results for all of Denmark for stroke and type 2 diabetes. And just here, again, it's entire Denmark, but here you can see that the population size is larger, and that's because we here focused on all persons more than 35 years of age. So we have 3.6 million persons. This is the period that we are interested in. And as I said previously, we identify all persons with stroke in the National Hospital Registry and in the Mortality Registry, and with type 2 diabetes using these two registries, Hospital Registry and Prescription Registry. And first, the results for stroke. And these I present a bit different, because here we did these linear, look at linear association. So, but I will take you through this table. So if we start with road traffic noise here at the most exposed facade, you here see the unadjusted risk estimates, and here you see the adjusted risk estimate. And how you interpret this 1.04 is like every time that the road traffic noise increases by 10 decibel, you will see a 4% increase in risk of having a stroke. So, and similarly for least exposed facade, every time that noise goes up by 10 decibel, you will see a 3% increase in risk of having a stroke. And just to say again, we saw a slight reduction in estimates after adjusting for air pollution, but not that much. It was rather robust to adjustment for air pollution. And here you see the results in a graphical way, road traffic noise at the most exposed facade, at the least exposed facade. And you can see here we actually saw a stronger association for the most exposed facade compared to the least exposed facade. Here, again, you have increase in risk. And you can see here the levels of noise, and you can see a nice, also here we have this trend for seeing some sort of leveling off at high exposures. We saw no association with railway noise at all for stroke. And for type 2 diabetes, same table. Again, it's per 10 dB increase in risk. And we have here road traffic noise at the most exposed facade, at the least exposed facade. And as you can see, again, we found stronger association between noise, road traffic noise and diabetes for noise at the least exposed facade. So every time that noise, road traffic noise increased by 10 decibel, we had a 10% increase in risk of having type 2 diabetes diagnosed. We also saw an association here. We have railway noise at the most, and at the least exposed facade, we also saw a bit weaker, but we saw an association also for railway noise. And again, this was rather robust to adjustment for air pollution. And here is again, here we have road traffic noise at the most exposed facade. You can see the levels here, road traffic noise at the least exposed facade, and especially look at this really, really nice curve where we have road traffic noise at the least exposed facade, where we actually don't see the same trend of a leveling off, but see an increase in risk across the entire exposure span here for road traffic noise at the least exposed facade and diabetes. We also saw an association with railway noise, as you can see here. It actually seemed to be a bit stronger for road traffic noise at the most exposed facade. But again, it's nice to see that the higher levels, also the higher risk. And I know that I always get questions regarding socioeconomic status. So after I have these presentations, people always ask me, isn't it driven by socioeconomic? Because people that are wealthy will buy houses that are placed where there's no noise. But actually, it's not that clear for Danish in Denmark, because what we can see is that people with high education, with high income, really want to live in central Copenhagen. So therefore it's not distributed as people actually think. I've included this table where we have road traffic noise below 55 decibels for the population. And here you have road traffic noise above 55 decibel. And here you have income. So you can see these persons have low income, these have median income, and these have high income. And you can see for income, if you compare people with low noise and high noise, you can see that yes, for income, there is a slightly higher proportion of people with high income in the less polluted areas. But if we go down to look at education, where we here have low education, medium education, and high education. And you can see if we look for education, we actually have more people with high education in the polluted area compared to the less polluted area. And we know from a number of studies on lifestyle that it is actually education that are more correlated to lifestyle, like smoking and other alcohol consumption compared to income. So just to say, the social difference with regard to road traffic noise is not as large as people actually expect. So to conclude, overall dementia, we found an association with both road traffic and railway noise, and especially with Alzheimer's disease. But this was one of the first studies on noise and dementia, and we therefore need more studies before we can conclude on noise and dementia. For stroke, we found a higher association with road traffic noise, and this is actually in accordance with a number of other high quality studies. And I think looking on the evidence that WHO had for evaluating high quality evidence for ischemic heart disease, I think that we are very close, if we are not already there, that we can also say that there are high quality evidence now for concluding that road traffic noise increases the risk for stroke also. We saw no association with railway noise for stroke. Then we have type 2 diabetes. Again, here we found both road and railway noise to be associated with a higher risk of type 2 diabetes. And there is a lot of studies already now also on diabetes. And again, I think looking at what we had in 2018 with ischemic heart disease, we have the same, I would say, quality of evidence. So I think we're also close to be able to conclude high quality of evidence for an association between road traffic noise and diabetes. So just in the end of my talk, I would just thank these two persons, which did a lot of the results I just presented. So Manuela Lecantuaria from Brazil, now employed in Southern University of Southern Denmark, did all the analysis on the dementia study. And Jessie Thatcher, a postdoc here at the Danish Cancer Society, was responsible for the analysis on type 2 diabetes. So thank you all for listening. And if you have any questions, I will be happy to answer.
Wow. Thank you so much, Mette. as always, really, really interesting to hear about your research. I can perhaps start off, you know, Mette, when you are at a party, right, or a social event similar, and you're telling people about your research and telling them, yeah, noise actually contributes to stroke and type 2 diabetes and perhaps even other things. Well, how do people react?
I think people actually now know, especially people I go to parties with because they heard it so many times before, but people actually know now that noise can be dangerous to your health. I would say 10 years ago, if I were to say that, people would look, even within research, even within environmental research, I met people that were looking at me like I was crazy, asking why I wanted to investigate whether noise at all could be harmful to our health, because nobody basically believed it, because like air pollution, they think that it's not something that are toxic to you. So it's but I think now already, and it actually went fast, I think, that 10 years after, people are actually aware, both socially, but also people that contact me when I'm out presenting data, they actually know now that noise is a health hazard, and that we have to avoid getting noise.
Thank you. And a question from Douglas Manuel, who is, of course, one of the big guns in the Danish sound industry, who says, thanks, Mette. Are there plans to repeat this study for aircraft noise? This is the third source included in the end of 2002-49. I'm not sure about that last part, but is there plans to repeat the study for aircraft noise?
We actually have aircraft noise already, but we could say that in Denmark, we are happy to have an airport placed on an island. So a lot of the issue in Denmark is that we don't have that many people exposed to aircraft noise, because we have placed our airport really strategically, which is of course good. So we have tried to look at it. Normally we have very few highly exposed, so it's difficult for us to see associations. We have for diabetes, for example, we tried to look at associations if you had kind of one source compared to two sources, transportation sources, and three sources, and we found that the more sources you were exposed to, the higher risk for diabetes also.
Okay. Okay, and we have one from Shao, who says, thank you, from Brazil. Where can we find the publications of the whole research? Is it out yet, Mette? Shelley, will we send this out to people or link them perhaps?
This
we
is
can link if it's available.
Yeah. I
Okay.
can send you, some of them are readily available online, but it's free publication, and I can send you the link for free publications.
And then there's a question, and I am very sorry, I'm going to butcher the name here, but I would bet it would be something like Xin Hu, who asks, is there a study on the health of people working at noisy environments? And I guess I could understand that both as indoors or outdoors, but he asks study on the health of working people in noisy environments.
Yeah, so occupational noise. There are some studies on occupational noise, not as many as on transportation noise. We are actually involved right now in a Nordic collaboration study where we want to estimate both the road transportation noise, but also occupational noise. And we just published a study on occupational noise and stroke, where we saw some associations, but not as strong as for road traffic noise. So I think you could say that there are some studies indicating an association with especially these cardiovascular disease, but it's inconsistent, and other studies don't find an association. So basically we really don't know yet. And you can say in occupational noise, you don't have this disturbance of the sleep. So it might also be very difficult to compare because it's so context dependent. This with noise, it doesn't combine, like for example air pollution. You can measure what you get over the entire day, and it is different for occupational noise. So it's in my head it's not easily comparable, occupational noise and transportation noise, simply because you don't have the exposure during the night.
Interesting. Reminds me that there are some studies that seem to indicate that access to quiet areas reduce the health risks of environmental noise. So I come to think that if you perhaps are working in an occupation with very low levels of noise, we could speculate that perhaps that would actually lessen the effects of the environmental noise. But that's just a speculation. But we have another question here from Niels Henrik Pontoppidan. I'll read his full name because I can pronounce the Danish names. Are you able to include in your model when during the day that the noise appears, e.g. freight trains, in the evening over some traffic, which is louder during rush hours?
No, this is not. We are not able to include these, unfortunately. There are some other studies I know on these freight trains, but it's not from Denmark. And it's more studies where you look at some individuals. So you measure noise, and you maybe have only 30 individuals that you then measure how that affects them. So no, we are not able to include that in our models.
Okay, and we have time for at least one more question. We have one here from one of my colleagues, Colin Campbell. Hello, Colin. Mette, how do you advise about quality of sleep in cities? Windows open for better air quality, but more sleep disruptions from noise.
I don't think you get better air quality by opening your windows if you live in the cities. On contrary, I think you will get a lot of air pollution flowing in immediately. But what I normally recommend is that people find a room to sleep in away from a noisy road. So try to have as quiet a sleeping room as possible.
Yeah. And there's been some innovation to this from Rambøll, who has like a sort of, I'm not sure how you put it, but you can slide these sort of slatted partitions in front of your window, then the air gets in, but the noise gets reduced. And then there's what's called Russian windows, which I guess is an old invention. Colin, you should look into that, because that has a lot to do with sound traps. Like, I know you know a lot about those. So we are going up until the end before we gotta go over to Kasper. So Mette, pleasure hearing from you and talking to you a little bit. So let's roll this on. Me and Kasper, in fact, did our master at the very same department at Aarhus University. So always good to see another sound designer doing interesting research. So there's a wide range of businesses working on expanding sound-based technological interventions for indoor environments. These interventions, I would say, are often controversial, sometimes even standards classify them as controversial, but more and more solutions are being developed by the industry, and more and more research is being initiated on these types of solutions. And maybe the ISOBEL project, of which Kasper is a part, will break through the sound barrier with their project, which he is here to talk about today. Kasper is a PhD fellow at Aalborg University. He has a host of interesting formal projects, including, for example, mediation of big data through sound. And he also has some interesting examples of these projects online, for example, on his YouTube channel, I believe. So Kasper, really good to have you with us. Looking forward to hearing about this, and take it away.
Thank you. And nice to see so many well-known faces. I'll just share my screen. Right. So do you see my slides?
Yes, we do.
Perfect.
Looks
All
good.
right. So thank you for participating at this exciting event. I'm here to talk about my PhD work within the ISOBEL project, where I'm investigating the experience and effects of dynamic sound zones. I'm a PhD fellow at Human-Centered Computing Group at Department of Computer Science, Aalborg University. So the ISOBEL project is a grant solutions project funded by Innovation Fund Denmark. And the project is a large research project where Bang & Olufsen, Sound Focus, WaveCare, Aalborg University have joined forces to respond to the need for sound exposure control in dynamic real-world contexts, adapted to and tested in healthcare and private homes. So we know some of the negative effects of unwanted sound. On the other hand, wanted sound, such as music and ambient sound, contribute to increased well-being and productivity and quality of life. However, what constitutes a positive soundscape is a much more complex matter, which varies across individuals, place, and time. So the objective of the ISOBEL project is to develop a new signal processing technology for making sound zones dynamic. And it is to develop a new interaction technique which enables users to understand and control dynamic sound zones, and to test these interactive and dynamic sound zones in real-world settings, including healthcare and domestic settings. Yes, so the scientific challenge within the ISOBEL project is, of course, to reduce noise exposure while providing wanted sound within limited spatial regions. So just to quickly take you through the initial vision and concept of behind the ISOBEL project, you can see here an illustration of these typical sound bubbles. This is, of course, a bit more complex. We cannot create sound bubbles. We can project audio towards intended listeners while minimizing the sound in other places within the same space. But these illustrate the concept quite well. So within healthcare, you can see we have a shared hospital space with two patients lying next to each other, and we have staff, hospital staff, monitoring the patients. So here we can actually create patient-directed and personalized audio experiences without disturbing other people within the same room. So the sound zone technology behind the ISOBEL project is a system that will respond dynamically to user needs and context and provide user control of wanted and unwanted sound. And sound zones enable multiple personal listening experiences within a shared space. So the overall aim of the ISOBEL project is to develop an interactive sound zone system that will be adapted to and tested within healthcare and private homes. And we conceive this technology as a soundscape modification. So this technology enables multiple personal listening experiences within a shared space. So yeah, with the overall aim is to, of course, to improve the soundscape of private homes and hospitals. The social context within homes, for example, with kids having different needs. We want to put the system out there and see what people can do with it to improve the context. All right. So the sound zone technology is capable of focusing sound towards each of the people within a room by doing so-called destructive and constructive interference. So our mission is to provide user control over these sound zones by making them dynamic and providing user control over different types of sonic parameters like volume, position, and width of these zones. So here you can see an overview, an illustration of a sound bar consisting of a loudspeaker array, projecting sound towards different people within the same room. So we have content from, for example, a television sent to patient A, and another content, for example, music, for patient B. And this is actually this is achievable with this new technology. Okay, so the ISOBEL project consists of 3 PhDs and 1 postdoc. So the user research components are investigating quality of audio experience. We are also investigating user interaction with dynamic sound zones. And my main focus is the user experience of these dynamic sound zones. So the challenges of within the ISOBEL project is to, at least the challenges that I'm working with, is to create an interaction design which facilitates the user experience, which makes these invisible and intangible sound zones tangible. And yeah, so while relying on the foundation of human-computer interaction, designing sound zone interaction poses a number of challenges in relation to user experience and the context of the user and the inherent constraints of sound zones in terms of invisibility and intangibility. So just to talk a bit about noise in hospitals, to provide some background. Within healthcare, noise is widely acknowledged, of course, as a problem. And there's several studies who have shown the negative consequences leading to prolonged healing processes and recovery times, as well as creating bad and stressful working conditions for staff. So, however, a singular focus on sound level reduction fails to consider individual sound perception and the potential positive benefits of wanted sound. So unlike noise abatement practices, the notion of soundscape seeks an understanding of the entire acoustic environment as experienced by individuals, acknowledging that sound level reduction does not necessarily create a more pleasant soundscape. So the soundscape approach that I apply through this project provides alternative ways to evaluate the acoustic environment by understanding the subjective experience and feeling of being in a hospital space in order to design for positive soundscape experiences. So in the following, I will take you through a concrete lab-based soundscape evaluation conducted within a simulated hospital environment. So before we are going into the wild with the new sound zone system, we have conducted a series of lab experiments where listening evaluations were captured to measure emotional and cognitive responses of individuals from hearing a hospital soundscape across a variety of sound zone interventions. So here you can see the physical setup that I've been working with. Hospital environments generally present pragmatic challenges along with ethical questions raised about exposing patients, staff, and relatives to experimental interventions. So we've conducted controlled lab experiments in a simulated hospital environment. And to increase ecological validity, the lab experiment was conceived as a controlled field snapshot through a simulated hospital environment. So listening evaluations were conducted with 2 concurrent subjects lying in hospital beds, visually separated by a curtain and dimmed lights to increase immersiveness. The simulated environment imitated a 2-bed intermediate care ward at North Zealand Hospital. And recordings from the hospital ward were used to recreate a multi-channel soundscape reproduction in the lab. And a 31-channel speaker array was used to focus sound towards the intended listener, using beamforming as the main strategy. So we recorded emotional cognitive responses, which supported the notion that the ISOBEL sound zone system enable multiple personalized sound experiences within a shared space and reduced perceived noise exposure. So these results, we consider them as indicative of providing potential benefits on health and well-being by means of psychologically mediated processes within hospital environments. And here you can see the results from one of the lab experiments, where the perceived calmness and reassurance of being in a hospital bed within an environment consisting of these different sounds. The perceived calmness of listening to relaxing music provided a more calming and reassuring experience. So the next steps of ISOBEL is to actually deploy the sound zone system within real healthcare settings. We have teamed up with the maternity ward at North Zealand Hospital, and we're preparing a longitudinal field study, which consists of an intervention and a control group. So here we have, we can see a 2-bed room where we're gonna deploy a sound zone system with 2 television screens and a set-top box. So patients can use pre-selected content and visuals to create a more calming environment for themselves without disturbing the patient next to them. So so the main objective of this is to actually investigate the experience and health-related effects of creating a more positively experienced soundscape. So the main question here is, how can sound zones improve the acoustic environment for patients and staff, and thereby improve health and well-being? So that's next step, and thereby I'm gonna finalize my talk. And thank you for listening.
Yes. Thank you, Kasper. So this project, how long have you been working with this this idea in the ISOBEL project?
Well, I've been involved in the ISOBEL project for the last couple of years, and I started my PhD in October 2020. And so we've come a long way. We had, of course, Corona interrupting the whole the planned field studies, but in the meanwhile, we've been doing all these lab studies. And the foundation actually is based on another PhD student, who created, a conceptual understanding of sound zones. So that's Stine Lundgaard, who's also involved in the ISOBEL project.
Okay, great. My old supervisor, Marie Højlund, who you probably also know, asks, did you consider other soundscapes than music for the next long-term study, such as nature sounds? And how do you choose the music for the studies?
Yeah, so we have some partners in the project, and we, of course, I've done a lot of research on what sound to actually include in the studies. Of course, we have a whole range of studies claiming that natural sounds have healing effects. We have the whole attention restoration theory, and a lot of evidence that this is actually creating a more pleasing and calming experience. But we have WaveCare in the project, who are delivering music, which consists of both musical elements but also natural sounds, so it's going to be a mix of different kinds of content.
Great. And I was considering how it's, if I remember correctly, Kasper, the patients have some sort of interactive effect on these sound zones. How do they control it, so to say?
Yeah, for this particular study, we're deploying in a month. That's the plan, at least. But in this study, we are just, we're giving out a remote that we've been busy preparing for this. So it's basically a remote to control the television, and the sound zones within this study is actually static in the sense that we have patients lying in hospital beds. They don't move that much, so we just create the position when we deploy the system, and then the sound will stay there for the deployment. Okay. So and then we're doing a lot of stuff behind the scenes, adjusting sound levels between sound zones and so on. So
for people perhaps not that into the whole idea of these sorts of systems, to explain Marie's question and my own, it's always the big decision how to make the sound zones or the system interactive and not repetitive, or something that people has a personal objection to because it's not their type, it's not really their preference, all this. So it's a really interesting part of Kasper's research. We have one here from Torben Holm Pedersen. Do you have any data on the noise reduction of the system?
Well, we have a lot of data on the noise reduction, but just to quickly explain the concept behind the sound zone system, it is not reducing noise from the surroundings. It is reducing noise between sound zones, so the interference between sound zones. So the content in one zone is minimized in the other sound zone. So that's and of course there's other concepts playing in here. We also work with masking sounds from the surroundings by providing especially designed sound for healthcare environments that masks alarms and stuff like that. So that's also something we are working with, but we don't have any active noise cancellation from the environment.
Cool. And that will, I guess, will also require an amazing amount of microphones or sensors and loudspeakers to really do that So, but it sounds really, really amazing. We have here from Maria Quinn, what are the baseline acoustic data for the shared rooms? Yeah, she's writing here reverberation time, speech level, and sound pressure level, of course, and so forth.
Yeah, well, I can't give you the baseline data right here, but yeah, the recordings and measurements were done at North Zealand Hospital by Martin Bo Møller, who is a research specialist in the ISOBEL project, and he's at Bang & Olufsen. So I just obtained these recordings and data and set this whole experiment up based on that. So yeah.
Yes, because I guess what is implied in this question is also that, you know, reverberation time will be affecting the actual system that you put into the room. So yeah, you probably need a low reverberation time and such to really make this work in a good way.
Yeah, well, that's of course some of the overall purposes of the ISOBEL project. That's actually to create a system that can adapt towards changing conditions and different environments. So this is something that the system will take care of.
Great. And just wanted to mention, Kasper, there's a lot of gratitude coming your way. People really like the talk. I'm just not reading up all the thank yous, but please keep your questions coming. We have a little bit more time than expected. Shelley is raising her hand.
Hello. Thank you very much, Kasper, for the talk. I just wanted to ask you what sounds do mask beeps and alarms? Is it some kind of electronic music with synthesizers, or what are you using primarily?
There's a lot of research in noise masking with sound. So using sound to mask other sounds could be, for example, just a very simple example is white noise or pink noise. This could elevate the noise. Elevate the noise floor so that you don't experience sounds in the surroundings as annoying or as sudden.
Yeah.
So that's what I mean by masking. Yeah. And of course we have Wavecare has a musician who is composing music that actually masks out specific frequencies from alarms and equipment noise and so on. So yeah.
Marvelous. Thank you.
And we have another one from Sin Q, and I'm again sorry to not being able to pronounce your name. Any benefit the noise can bring to the health? And I suspect that what is meant by this is, that your masking sound or your system, can it sort of contribute to health and not just, eliminating other noise?
Well, yeah, I'm not sure I understand it completely, okay. But is it related to the sound zone content or?
We will have to just let this question hang there for a second. Perhaps Sinq can add more information. Torben Holm Pedersen asks, masking sounds will increase the total noise. Will that contribute to increased annoyance, perhaps?
Well, for the whole concept of masking sounds is not to create more noise. It's more a concept of creating less perceived noise in the surroundings. So if you, for example, use white noise machines, pink noise, stuff like that, this will, as you know, when you stand in a kitchen, for example, and turn on the what do you call it? The water, and so that will create some masking sounds that it's it's more difficult to, for example, hear what people are saying in the room next to you. So it's more like if the lowest ambient noise in the surroundings are very low, if it's very quiet in an environment, even the most subtle sounds could create a stressful reaction, and you can hear a pin drop, if you are in a silent environment. So this is just creating a floor of noise that you can just experience like being in the background of your consciousness, and this will create a more perceived quiet environment.
And Shane Cryer from the UK asks here, Harry at what university? Scotland explored this a couple of years ago and put forward the argument that only natural masking sounds, e.g. running water, low frequencies, are best for human beings. And he asked you if you would like a copy of this research. I think you should just be able to comment on it, but for context for all our listeners, this is again back to the choice of masking sounds, and Kasper mentioned earlier that there's a lot of research to go along with the idea that natural sounds like from birds or water or similar is something that people can easily tolerate over longer periods. But what do you think about this, the natural sounds again? You probably have looked into it, I would imagine.
Yeah, and we're also using natural sound. So it's of course, yeah, I agree with that, and I don't think it's nice to listen to white noise, for example. Some people do, but not me. So, but yeah, definitely pouring water and stuff like that. That's running water is better, of course, and. We just have to have a broad frequency spectrum, but the naturalness of sounds is of course something we're working with. Yeah.
Perfect. I think we're gonna swing back for a minute because I did a little mistake and didn't watch the Q&A section of Zoom quite close enough. So also to perhaps have a little bit more back and forth here in the end, Mette, I'm going to go back to you for a second. There's a question in the Q&A that I missed. And it goes, hi, thank you for a very interesting talk. How did you handle people moving within the 10-year time span? Did you or Rambøll validate the traffic noise estimations by doing long-term recordings of people's positions?
We didn't do any validation. I am being constantly told by acousticians that the measuring compared to modeling is you shouldn't go there because the modeling is better than the measuring because you have so many different types of noise. So that's at least what I was told, because I came from the air pollution field where we always need to validate, but I've been talking to so many acousticians that have been telling me that I shouldn't validate the model. So I kind of listened to them. So I will have to refer to Rambøll or other acousticians to answer this part. Regarding adding or including moving. So basically when we calculate a time-weighted mean the last 10 years, we take into account that maybe you spend 3 years in one address, 2 years in another, and 5 years in a third, then we take a time-weighted mean during these 10 years. So that's how we handle it in the analysis.
Okay, great. Another question from you from me, Mette, this time. We in Denmark have acquired, we have a lot of data on our social security system through our CPR numbers and such. Do we have a sort of unique opportunity in Denmark to do research such as yours? Or could we do similar research in the rest of the world?
No, we have a completely unique situation in Denmark. And as I said during the presentation, some of our Nordic neighbors have something similar, but our registers actually date back longer than the Swedish and the Norwegian and the Finnish. So I would say that in Denmark, we are able to do studies that are just not possible in any other countries. When I talk to colleagues from UK, from the Netherlands, they are so envious because we are able to do something that they will never be able to do on a national basis. So it's completely unique that we have this possibility in Denmark.
Okay. So that sort of makes me a little sad, because we will have less opportunity to replicate and see how it is in other places in the world. There's a rephrasing of the question to you, Kasper. So now we're really going back and forth. And it's regarding this of how sound could contribute to health. In telecommunications, comfort noise is used to replace silence to make a conversation feel more natural. I'm wondering if adding some noise to a quiet environment may help health. And for context, if somebody here is not very aware of the field we're talking about, noise levels in hospitals are quite high and going above, rising steadily, at least if you look at big studies on this. But it's an interesting question, Kasper. If we're living in a completely silent environment, too silent, do you think we could contribute to health by adding sound?
Definitely. I don't think that quietness is necessarily a quality indicator of a pleasant acoustic environment. I think that when you're, for example, in a hospital, you're much aware about your surroundings, and you want to be aware of what's happening around you. So if you can't hear anything and you have noise cancellation headphones on, for example, you are isolated from the surroundings, and that could actually induce anxiety and stress. And there's other issues with headphones, for example. So definitely adding sound in a quiet space is definitely preferable in most situations. And yeah, so it's not about silencing the surroundings.
No. In fact, a completely sounded room is well, I think there's some sort of like myths almost from people to person saying that if you were in a completely sounded room, you would hear your blood in your veins and everything, and all of that stuff is of course nonsense. But being in a completely sounded room is not pleasant to me. But luckily, we don't see that often in real environments. Guys, we have no further questions at the moment in the chat. So I think I will take a couple of my own.
Martin, can I just mention that this subject of silence or an acoustically dead space and the effect of our health is something we've been looking at in our healthcare and welfare working group, and also our environmental working group. So it is a topic people are bringing into conversation frequently, and there's a few studies going on with companies like Covey, and I can't remember if there's something with Echophone, not about office.
Specifically on adding sound or
adding sound, yeah, because people are not comfortable at work in these huge open plan spaces. They've done a lot of work to make it acoustic, to put the acoustic treatment in, and then they find out that they can't eat an apple or because they don't want to disturb their colleagues.
Well, that's actually a sort of very well known, and it's nice that you asked that question, Shelley, because it's a thing that is really going around. So it is true that if you have a completely sounded environment where there's no real reflections of sound going on, you will feel it as sort of unnatural. But luckily, we almost never see this in any spaces. So if you, for example, imagine an office And you pretend, now we imagine an office that has really a lot of acoustic absorption going on. So it will have a high absorbing ceiling, it will have screens, it will have wall panels, all of this. Then still you will have the desks that will provide you reflections. You will have the screens, computer screens. You will have the furniture. You will even have the people, the heads of people in there. So I've never experienced office that has been over dampened. I know it can happen, and there are studies on this, but I've really run into this question almost so many times, but also sort of as a little bit of an a challenge, saying, don't you just want to dampen everything towards a place where you can't even be in there because it's so quiet? And I usually say, if you can find me that building that is so quiet that people can't even be in there, I will come and measure it for you. I will document it, and we can do a study together, and I will buy you dinner. But so far, nobody has reached out, but that invitation is still standing. And still we now looking at the new office standard, ISO 22955, and that has new target values for offices that is in the end based on signal to noise ratios. So that means that in the end, it's not just the noise in the environment, it's actually in offices way more to do with, can you hear other people speak? Because if you're in office, you're there to work. So you want to have, your mental capacity open to yourself. And if you're listening to words coming in, it's really hard to cognitively keep going. So that is actually a question of signal to noise ratio. You want enough noise and dampening between two positions, so you can't hear the conversations going on around you too clearly. So there's some truth to that, but it's really more complicated than just, you can over dampen a space or not. In effect, over dampening almost never happens. Well,
watch out. We will hold a webinar on the topic later this year, so we can invite you back to be moderator.
Perfect.
Good.
So let me see.
I have another question, if there's no. I was just curious, Kasper, have you been in contact with Helle Nystrup? Not because she's at Aalborg University as well.
No, I don't.
No, she's a music therapist, and she is either at Aalborg or was there, but she has a startup called Music Star, which is an app for music therapy. And I've had a great discussion with her about the importance of having options, preference, because some people, not everyone is relaxed by the same kind of content. So I've been trying out her app. It's great. You should check it out.
Preference is of course a huge thing, and so this is why we are also providing for these long-term deployments of the system. We're providing this set-top box with you can say it's like a smart television, where you can use your own, see your own content, listen to your own content, or you can select some of the content that we provided with the system. So and that's of course very important. Yeah.
Great. I'll write this in the chat so that Fabien has it.
Yeah. And Lars Søndergaard says here, Morten, at Internoise in Hong Kong some years ago, a team went to Svalbard to measure the acoustics in an ice cave, and they only measured the instrument noise. And then blinky smiley face. I'm not sure I understand, Lars. Could you elaborate? And let's see.
I think he means that it was very quiet.
Oh. Yeah. Well, we don't sell
quiet
much
in the ice caves.
To ice caves, though.
And there's a question for Mette in the Q&A also.
Yep. Just lost track of the Q&A there for a second. Had too many tabs open. I'm sorry. Perhaps you could take it, Shelley.
Yeah, this is from Morten Messen. Thank you for the presentation. Your research considers how noise levels have an influence on certain health issues. Is there any research that indicates what influence the characteristics and sporadicity, etc., of noises and sounds have on health?
Yeah, this is a really great question, and this is something I would love to go into, actually being able to do some research on. So far, I've only seen studies from Switzerland where they try to look a bit on the intermittency of different noise sources, but I wouldn't say that we can conclude anything for that, because I also find it interesting. Is it the high the acute high noise levels that are causing the problem, or is it this continuous noise that are actually responsible for the association we see? And at present we don't know. We have no clue because there are no studies on it. So also if anyone here has any ideas on how we can estimate that using studies like I'm doing in a large population, that would be great, because we are really eager to do studies where we try to look a bit more into this also with regard to health, to try to elucidate more what is it in noise that are causing these health effects.
I suppose it's difficult to find that data for a large scale and also over a long enough time.
Yeah, because it's something that we need to somehow be able to modulate. Yeah, I haven't found a way to do it either so far.
Yeah.
Yep. It doesn't seem like there's more questions. We're running up 3 minutes against the end of this seminar. So I will just say thank you for my part and let Shelley round this off.
Thank you very much, Martin, for being here. And thank you to our two speakers today. Do you have any final words? Not from you? Well, I would just like to say that Force Technology has released, I think it's 3 podcasts about traffic noise that Mette is in. And I haven't had the chance to listen to them yet, but we'll send the links out afterwards, as well as the presentations. And also Mette will be speaking at BNAM, which is the 9th to the 11th of May this year. So if you're going there, you can check out her keynote speech. And I saw yesterday a link to a BBC episode about noise in hospitals. So I think we'll include that as well. Again, I haven't had the chance to listen to it yet, but it looks very interesting for those of you interested in these topics. But yeah, thank you very much for being here. And thanks to our audience out there. I hope you enjoyed it. And we're going to send out a lot of stuff, including a questionnaire. So if you can spend 1 minute filling that out and giving us a bit of feedback, that's very useful for us in the Danish Sound Cluster as well. So thanks to everyone, and see you for another webinar sometime soon. Bye.
Thank you.
Thanks.